We'd like to welcome our next presenter, Dr. Stacey Winham from the Mayo Clinic. She will be discussing radiomic phenotypes of breast texture in association with breast cancer risk and masking.
Thank you to the organizers for inviting me to speak today. I'm glad to be here. I have nothing to disclose. Digital mammography is used for routine breast screening with the goal of detecting breast cancer, but breast cancer risk factors are also present on radiology images years before the cancer develops. One of these is breast density, the amount of fibroglandular tissue. Another is the parenchymal pattern, or the breast texture, which is illustrated in the images you see here. These are mammograms from two women who both have similar levels of breast density, high BI-RADS density score, but they have very different breast texture patterns. In image A, you see a very smooth texture, whereas in image B, you see a much more coarse and complex texture. So breast density and parenchymal patterns are different. They both independently predict breast cancer risk. They've also been shown to be associated with masking or missed cancers. We know how to quantitatively assess breast density. There's a number of methods already available to automatically and systematically assess breast density, but it's much less clear how to quantitatively assess the parenchymal pattern. How do we quantitatively distinguish the images on the left and the right? And this is where the idea of the radiomic phenotype comes in, where we use a large number of parenchymal features to define a phenotype. So our group has previously developed an automated pipeline to extract hundreds of quantitative parenchymal features. And we've previously applied this pipeline to extract a subset of features, shown here as the rows of this heat map. And we use these features to define and reproduce a set of 4 radiomic clusters or phenotypes, shown as the columns of the heat map. And these radiomic phenotypes were associated with breast cancer risk in a small sample previously. Here we are interested to see if these results scale up to a larger and a more diverse sample set. So our study had 2 main objectives. The first was to define intrinsic breast radiomic phenotypes based on the parenchymal features from full field digital mammography, or FFDM. The second was then to assess whether these radiomic phenotypes are associated with breast cancer risk and masking. So we designed a study within 2 phases. The first phase was a discovery phase for identifying these radiomic phenotypes. We had a large sample of 30,000 women with 4-view FFD images. These women came from 3 breast screening cohorts. They represent a spectrum of racial diversity with 3% Asian, 33% Black, and 61% white women. Among these 30,000 FFDM images, we extracted 390 parenchymal features. And we split these women into a training and testing set to use these features to define our radiomic phenotypes. And then in the second phase of our study, we applied these radiomic phenotypes to an independent sample to assess breast cancer outcomes in a set of roughly 1,100 cases and 2,800 controls that were matched to the cases on age and race. So when it came to defining these radiomic phenotypes, we extracted 390 parenchymal features from 5 high-level feature classes: the gray level, co-occurrence, run length, structural, and multi-resolution texture features. We batch adjusted these features to remove technical artifacts, and then we computed these features at lattice points across the breast. And then we summarized the features across those lattice points using measures like the mean, median, standard deviation. We then used these features to define our radiomic phenotypes agnostic to the breast cancer outcomes. So we used unsupervised learning and 2 different approaches: hierarchical clustering and principal components analysis, to define our phenotypes. We trained these phenotypes in a set of roughly 20,000 women, and then we evaluated their reproducibility in a testing set of roughly 10,000 women. We also stratified and retrained the phenotypes by race and density groups. These are the demographics for our training set, shown overall and then separately for white and black women. Demographics were similar in our testing set. We had a mean age of 57.4 years, mean BMI of 29.2, and then roughly 35% of the women had dense breasts, defined by BI-RADS 3 or 4. Using hierarchical clustering, we identified over 40 clusters that were significantly identified in the training set that also replicated in the testing set. And then among these clusters, we selected the top 6 that had large sample sizes greater than 1,000 as the most robust and had the greatest power for assessment of association with risk in our case control sample. These clusters are defined here across the columns of the heat map. The features are defined across the rows, color-coded by feature class. The scale refers to the actual value of the feature, where blue is a high feature value, red is a low feature value. For patients in cluster 1, they have relatively low values of the median co-occurrence laws features, as compared to patients in cluster 3 that have high values. We saw similar patterns when we stratified by race and density groups. So these clusters allowed us to define radiomic phenotypes that were in discrete categories or classes, but we were also interested in assessing phenotypes on a more quantitative scale, and so we used principal components analysis, where we fit PCA in our training set and applied it to our testing set. The first 6 principal components explained 85% of the variability across the feature values. I'm plotting, again, the PCs as the columns across the heat map, the features themselves as the rows. But the patterns on this heat map are a little different than the one I showed you previously. I'm not plotting the individual feature scores as the scale, but rather the feature loadings or the weights from the PCA. So blue indicates a high positive weight, red indicates a strong negative weight, whereas this kind of yellowish beige color indicates a very low weight for that particular feature. So for PC1, the features that are weighted more heavily include the median co-occurrence laws, where these features are not weighted in the second principal component. So then we carried forward these radiomic phenotypes in the second phase of our study to our independent case control sample, where we assessed the association of these phenotypes with breast cancer outcomes, including risk of development of future cancer, also false negatives, defined as diagnosis of breast cancer within 12 months of a negative screen. We also assessed associations with a subset of false negatives, symptomatic interval cancer, which were women that presented with symptoms within 12 months of a negative screen. Associations were assessed with conditional logistic regression, adjusted for age, BMI, and density. We also stratified analyses by race. In terms of evaluation of association, we used the likelihood ratio test to assess statistical significance, and we used AUCs in 95% confidence intervals to also assess discrimination. These are the demographics of our case control sample, roughly 1,100 cases matched by age and race to 2,800 controls. We see expected associations with breast cancer risk factors, including higher BMI, higher family history, and higher density among the cases. And these are associations of our radiomic phenotypes with risk of overall invasive breast cancer. This is specifically for the radiomic PCs. So I'm plotting the ROC curves and corresponding AUCs, first for invasive breast cancer for all women, and then separately for the white and the black women. These ROC curves in red indicate models that are adjusted for age, BMI, and BI-RADS. The curve in blue then also includes those radiomic PCs in the model. The PCs were significantly associated with breast cancer risk overall, both before and after adjustment for the covariates. However, as you can see, the improvement in discrimination was more modest, especially for all women, where we see little separation across the curves. But when it comes to the black women, we actually see a much larger increase in discrimination, where our AUC increases from 0.627 to 0.685. Similar associations were observed for the radiomic clusters, although they were somewhat attenuated. Here are results of our radiomic PCs with false negatives and with interval cancer. Again, we saw that the PCs were significantly associated with false negatives and symptomatic interval cancer, both before and after adjustment for the covariates. However, the improvement in discrimination that we saw for false negatives was greater than what we saw for invasive cancer overall. And in particular, it's most pronounced for women with symptomatic interval cancer, where we see an increase in AUC from 0.686 to 0.762. Again, results were similar for the hierarchical clusters, although somewhat attenuated. So in conclusion, we have identified reproducible radiomic phenotypes that are associated with invasive breast cancer outcomes, and these are independent of breast density. These associations were strongest among Black women and women with symptomatic interval cancer. And although the associations were statistically significant, the improvements in discrimination were modest. And although our radiomic phenotype discovery set was very large, we were limited in a smaller sample size for risk associations, particularly for subgroups, especially for our masking traits of false negatives and symptomatic interval cancers. Additionally, these phenotypes were developed on 2D mammographic images. Most breast screening practices have moved to 3D imaging with breast tomosynthesis. In the future, we'd like to validate these findings in a larger and more diverse sample set, and in particular, extend our radiomic phenotypes to 3D tomosynthesis. We would also like to compare radiomic phenotypes with molecular features, such as breast cancer molecular subtypes and other genomic features more broadly. We would also like to compare these radiomic phenotypes with other imaging methods, in particular, AI methods. Of course, this work was a wonderful team effort, and I want to make sure to thank all of my amazing collaborators and colleagues, those at Mayo Clinic, UPenn, UCSF, and WashU. Thank you very much.
Okay, so we'll start with a question from online. There's a couple questions asking about future implications and how you think this might affect women needing MRI screening and if it could eliminate the need.
I think it might be a little early to define whether it could eliminate the need, but I can see the potential, knowing that our associations were strongest, especially for the missed cancers, the false negatives and the symptomatic intervals. So it's possible that these phenotypes could, in the future, identify subsets of women, but a lot of work still needs to be done.
Super. And then in person, and we've been asked by audio to remind all of our Q&A speakers to speak directly into the microphone. We'll take microphone 3.
Matteo Bocci from Lund University. Thank you for the very interesting talk. I was just wondering whether your radiomics phenotypes are actually informative or reflective of other intrinsic biological stromal features like, I don't know, macrovascular invasion or immune infiltration.
That's a very excellent point and something that we have not looked into yet, more of the details about what these phenotypes are actually representing. We did exclude, we did a pretty extensive QC procedures where we excluded women that had potential artifacts on the mammograms, but beyond that, we haven't explored any other potential associations.
Thanks.
Okay, we have another online question, and a lot of these have actually been from Regina Rosenthal, and it's asking if you can, if you can comment on lobular versus ductal cancer detection.
I wish I could. That's actually something we did not look at within this sample set. We did not examine lobdal versus ductal, and would be something interesting to investigate in the future.
Okay, thank you.